So I have worked in both NHS and I have worked in private practice for 14 years now. Definitely, the practice can be very different based on the policies. So the NHS policy, like you already mentioned, the actual testing starts because the human reproduction is a very inefficient process, and one miscarriage is way more common than someone otherwise imagines. So one miscarriage is very common, and based on the NHS policy, they have fixed the number of three. So in the third miscarriage, they promote that if this happens this time, the third time, then the products of conception are checked for the genetic problem in the product of conception first. And if the products of conception have any genetic abnormality, then both the parents are checked for the genetic problems. This works a bit differently in the private practice, though, because in the private practice, patients are paying for themselves or their insurances, and they have the right to ask the doctor to do the tests either after first or mainly second. So having two miscarriages also can be mentally very traumatizing. Um, Not an easy thing, both for the man and the woman, to see even one miscarriage, but two sometimes can affect the couples massively enough that they do come to us and tell us to test. So the same test we do at the second miscarriage. We try to do just the TLC, the tender loving care thing at the first miscarriage, and this large percentage of the people do not have any problem. But if someone has two miscarriages and they ask to do more tests, and they are prepared financially to just test that and find out what's going on, then we do check, like I just mentioned. First of all, we tell them if at all the products of conception are available in the second one, we test that. We do the genetic testing of the both the parents. We check for any antibodies, especially depending on the age of the conception, at what age. So if it was nearly up to so it was under 10 weeks. So first of all, early miscarriage or first miscarriage, first trimester miscarriage, most common causes are the genetic abnormalities. So the largest chunk of the first trimester miscarriage is the genetic abnormality. So we definitely would promote the patients to bring the products of conception, or if it is a surgical, we send it from the hospital. And then we check the parents for the genetic abnormalities. We also check for, like I mentioned, the antibodies, infections, any problems related to the NK cells. We check the blocking antibodies. We take the biopsy of the endometrium. There is a test called endometrial immune profile that we do that, in which we see the CD56 and the interleukins levels, whether they are acceptable or they are to be treated. We can always do more tests, newer tests. There is a test called KIRS, which is an endometrial biopsy. So we wait for the day 21, making sure that the patient is not pregnant and they are asked to have abstinence, because otherwise day 21, very initial pregnancy can be present. So we take the biopsy. MI and LS can always be done, but they are not very relevant at this point. But sometimes this biopsy is associated with MI and LS also. I generally carry a cover of doxycycline for such patients for the next treatment anyway, regardless of the reports of the MI and LS. And like this, we go more horizontal and cover all the various aspects. Th1, Th2 ratios are counted and checked. LAD, the leukocyte antibody detection test, is done. So we have this whole battery based on the typical history of the patient. Some of the tests might not be relevant in some couples, but I can't go to this detail in the interview because this actually is related to a lot of history points in the both sides of the couple. But then checking horizontally, meaning checking every area, is very important as compared to why I'm emphasizing is because I know of some teams where a lot of testing is done in one aspect, and quite a lot of grands of pounds patients have spent, but something else which is very basic like an APLA antibody, antiphospholipid antibody, was not checked. So we shouldn't be missing things like that. So the protocol setting of the unit has to be very carefully planned, so that at least we go stepwise, because this can involve massive financial aspect which affects everybody very differently, and it should make sense, what we are doing. So yeah, miscarriage can be a very tedious situation for some, but the good thing is that without doing anything also, the chance of having a successful live birth in the next chance is massive, even after 3 miscarriages, just because the human reproduction is a very inefficient process per se on its own.